Good afternoon, everyone. Welcome to our fifth in the series of our Trauma-Informed Care Wednesday webinar series that we've been doing. Today, as a take two from last week, we are doing cultural competency in the long-term care setting. You do not have audio and video as we're in a webinar format, so use your chat. If you are signed on the way you registered, you do not need to put information in the chat box to let me know you're here, because it will register your attendance through Zoom. If you have multiple people in the room with you, please let me know who's in the room with you and what CEUs you're requesting so I don't miss you when I do certificates later this week. And without further ado, because I can't think of anything else more important to say, then Suzanne is going to introduce Liz Wheeler.
Thank you, Susan. Thank you both.
Good afternoon, everyone. We're so pleased that you're able to join us again today. It is my pleasure to introduce Liz. She is an experienced leader in skilled nursing and assisted living, as well as long-term care pharmacy consultant. She's worked in various areas of care, including skilled nursing, subacute rehab, assisted living, memory care, palliative care, and pharmacy. Her main focuses are regulatory compliance, behavioral health, trauma-informed care, infection prevention and control, and quality assurance. Over her career, she has obtained and maintained CMS 5-star ratings and excellent survey results, and assisted many nursing leaders to improve processes and outcome. As an RN consultant at Leaderstat, her work includes assisting nursing facilities in managing day-to-day operations in regulatory compliance, development of plans of correction, guidance in facility preparation for resurvey, education and training, survey recovery, and clinical documentation requirements. Gosh, couldn't get that out. So it is my pleasure to hand things over to Liz. And Liz, we just can't tell you how happy we are that you're able to join us today.
Thank you, Suzanne. I really appreciate that. And we will not have any technical difficulties this morning. Well, it's morning here in California where I am, afternoon for you all. So thank you so much for joining. And I hope that you were able to attend some of the previous sessions as they build on each other. However, I will do a brief overview of trauma-informed care at the beginning, just to catch anyone up that was not able to participate in previous sessions. The focus of today will be cultural competency in our skilled nursing settings. And certainly if you have questions throughout, feel free to enter them in the chat. We'll also have a Q&A at the end if anyone has any specific questions. So with that, we'll go ahead and get started. Again, we'll be reviewing different cultures that have been changing in long-term care over the last several years. We'll also talk about current barriers in long-term care as it relates to trauma-informed care, and also how to cater activities for a more resident-centered approach. And activities meaning not just your recreational therapy departments, those types of things, but overall activities within the centers. And then lastly, we'll briefly talk about the quality assurance process and how to include your cultural based care into your QA processes and your QAPI committees. All right, Susan, I know I had sent you a poll question, so if you'd all take a moment to answer this. I just want to have a general idea of how you feel your trauma-informed programs are coming along. There's no wrong answers. If you haven't started yet, that's fine. I've shared tools previously, and I'm happy to send those out again. So feel free to answer.
Can you see the poll, Liz?
Yes.
Okay. And I see I have a typo. It's running perfecting. Apparently, when I did that last week, it was preemptive to what we were going to have happen in the Zoom meeting. So answers are still rolling in. So we'll wait a few more seconds.
Great. What did I say about not having technical issues? My slides keep changing.
It's just excited to be here and trying to get ahead of the game.
Like trying to get ahead.
It's all good.
So The poll disappeared. It was popping up for me. So maybe you will have to tell me because it disappeared.
Share results.
Oh, there it is. Okay. All right, so in progress, that's great. And if you are running perfectly already, that's great. Hopefully you'll be able to share some of the things that you're doing on best practices in your center. So feel free to share those in the chat. So thank you. All right, so let's do a brief overview of trauma-informed care. Again, trauma is experienced by everyone differently. It includes incidents or situations that can be disturbing to individuals. Some are life-threatening, some cause an ongoing disturbance to functioning. But again, everyone experiences trauma differently. As it relates to federal regulatory language, the F-tag that's associated with trauma-informed care is F699. And then that does state that facilities must ensure that residents who are trauma survivors receive culturally competent trauma-informed care in accordance with professional standards. The main focus of this trauma-informed care is to eliminate or mitigate any triggers and prevent re-traumatization to our residents. And so if you don't take anything else from today, keep in mind the main goal is to prevent re-traumatization based on the care we're providing, the work we're doing in the facilities, even if it is unintentional. We all experience trauma differently, and I've shared on previous sessions that I have had some trauma as it relates to the pandemic. I think many of us would agree with that. Also natural based disasters such as hurricanes, tornadoes, those types of things. And so not all traumas are experienced the same way for every individual. Some other trauma that you may be screening for would include physical or emotional abuse, history of sexual abuse or assault. If you're taking care of veterans, they may have diagnoses of PTSD, but not necessarily. And so be aware of who has experienced terrorism or experienced war in any way. I've already mentioned the natural disasters. Car accidents, divorces, deaths of friends or other loved ones, and then isolation and fear. Admitting to a long-term care facility in itself could be considered a trauma, giving up independence, losing your home, your financial independence, your friends and neighbors. All of that can contribute to experiencing trauma. So do keep that in mind as well. I will share a trauma screening tool at the end of the session. I'll email it to Susan so she can disperse. You may already have received it if you attended the previous sessions, but I want to make sure everyone has a copy. Some principles of trauma-informed care, safety, definitely at the top of the list. We want to make sure that we're fostering a culture of safety within our centers, not just for our residents, but for our staff as well. Pushing for trustworthiness and transparency, having open communication with residents about process changes, those types of things. And then offering peer support. We all experience trauma at work in some way or another. We just may not carry it with us. And so making sure that we are offering support to our staff and our coworkers as necessary. Just checking in sometimes can be sufficient. Collaboration and mutuality, very, very important, making sure that residents are included in their care planning processes, developing interventions, identifying their triggers, and then also including families and friends or other relatives when it's necessary and appropriate. Making sure that everyone has a voice, they're able to make choices. Resident rights are not new, but as it relates to trauma-informed care, making sure that the residents do have a say in the care that is being provided is very important. And then lastly, and our main focus of this afternoon's presentation will be the cultural, historical, and gender issues. All right, so let's jump into that. So some areas that need to be covered in your centers as it relates to cultural competent care would be working towards eliminating biases. We all have biases, whether we realize or not. And so being able to identify those as a team and discuss openly is very important. Making sure that we're appreciating other cultural differences. I've done a lot of work in West Virginia, and there's people from all over. There are a lot of locals in the facilities, and so making sure that we are aware of people from out of state, out of the country. Maybe they have different food preferences or music preferences, those types of things. And so just being able to identify that, and then also accommodating for any preferences as long as safety is maintained. So this could be food related, mealtime related, and the key is to make sure that we're care planning around those interventions and processes. Paying attention to culture and gender. I get a lot of questions about whether or not if a resident has as a caregiver gender preference, if that can still be accommodated. And the answer is yes, as long as it's done properly, especially if we are working with a sexual assault survivor, things of that, things along those lines or situations along those lines. It's important to maintain their idea of safety as well as protecting your staff. So just to keep that in mind. And also making sure that we're aware of spiritual beliefs. Again, if you have church services coming into the center, be aware of your residents' spiritual beliefs and that you're covering all areas that need to, not just having one religious organization offering those services. Some other F tags that are associated with cultural competent care, 656 and F659, which that's your development and implementation of comprehensive care plans, and then also those qualified persons that develop the care plans. And it's imperative that those care plans meet the professional standards of quality, that they're developed by qualified persons, and then also that you are accounting for any of those identified cultural differences and accommodations, as well as trauma triggers and interventions for those triggers. And then most of the citations that we see related to this really stem from a lack of training, which is one of the reasons that we're doing these sessions, is to make sure from the top down, we all have a general understanding of what trauma-informed care is, and then we're seeking out answers to cultivate and develop those programs in our centers. I also see, I want to jump back really quick to the 656. I also see in centers where a lot of the work is being done. The staff are aware that certain food preferences, for example, are needed, mealtime differences are needed, but then it doesn't map over to the care plan. So making sure that you're documenting and taking credit for those things that you're doing is very important. What do they tell us? If it's not documented, it didn't happen. Some other F tags that we see associated in citation risk would be F740 for behavioral health services. And overall, this talks about making sure that your centers are providing behavioral health that focuses on the resident's whole emotional and mental well-being, which does include cultural differences in care. You may have noticed with the ROP updates late last year that there's also wording related to mental disorders, specifically substance use disorders. And so you want to make sure if you are caring for individuals, which unfortunately, we're seeing more and more residents in our centers admitting with either a history of substance use disorder or an active substance use disorder. And I would argue that that's a subculture. You know, depending on where they're at in their recovery, you need to be aware of resources that those individuals need and be able to provide that. The recovery communities in your area may vary depending on where you're at in the state, but knowing where those resources are in your area and being able to provide them on some level to your residents is very important. So when we talk about culture, it's not necessarily focused on religion and food preferences and those types of things, or even gender identity. It's really what types of people are you taking care of, and what are they used to in their everyday lives? And, you know, do they go to the grocery store every day? Do they meet with a group of gentlemen in their neighborhood to play cards every week? All of that is considered a form of subculture. The 4 R's of trauma-informed care, just to cover briefly, would be the realization. So this is what is trauma and how does it impact your residents? How can we improve communication and shift our priorities? And then secondly, recognition. This is your assessment pieces. So how are you assessing as a group and as an IDT team your residents' past traumas and signs and symptoms of trauma? And then how are we offering support to those individuals? Response. This involves your policies and procedures, care planning, training, and identifying triggers. And then lastly, resisting that re-traumatization, which is our sole goal. So making sure we're offering choices and not labeling people by their diagnoses or their past traumas. And then also avoiding arguing, criticizing, being rushed or distracted can be a sign of being dismissive or disrespectful. And so be very cautious when you are assessing and discussing with the residents what their preferences are, that we're not passing any type of judgment, even if it is not intentional. Some examples of triggers could be a person. So I use an example of a resident when I was a brand new nurse. He was from a memory care unit and he admitted to rehab for a hip fracture repair. And the first time I cared for him, I leaned over his bed to check his vitals, and he tried to strangle me with his stethoscope. And so when his daughter came in a couple of days later, as soon as she saw me, she said, "Oh my gosh, you look just like so-and-so." And we realized that I was his trigger. He had a female relative that looked very similar to me that had exploited him financially. And in his demented state, he thought I was her. And so sometimes we don't realize what we're dealing with until we involve families. So I strongly encourage that you discuss with them as well as the residents. Feelings, so a feeling of worry or stress. Well, we all feel these things. Panic, talking about discharge notices, those types of things can all instill these feelings in our residents. So be aware. Especially homelessness. You know, I see some residents that before they admitted to the SNF, maybe they were having some financial issues, or maybe some of them have lived on the streets for several years. And so they're very worried about their discharge plan. They're worried about how they're going to afford medications and those types of things. And then also scents, sounds, anniversaries, those types of things. Specifically, I want to focus on the anniversaries here. So many of us are aware that we have certain anniversaries like 9/11 that come around. We need to watch for individuals that this could be stressful for, watching the TVs that are on in common areas and things of that nature if we're worried it might trigger someone. As we care for individuals over the next few years, we're going to see other things. We might have some individuals that are very stressed about the pandemic We may have refugees from other countries that we're caring for that have seen war and famine and things that many of us are grateful and lucky enough to never experience. And so we need to be aware of what some of those dates could be. And without having discussion with the residents and families, we may not be able to identify those risk factors. Just some definitions to cover, and these are pulled directly out of the state operations manual as well as SAMHSA. And so I really like how CMS, I don't say that very often, I really like how CMS pulled from mental health resources to develop some of this regulatory language. They've also included several links in the state operations manual. I've also included several of those links on the reference page to this presentation, so you will have access to those as well. But the definition of culture is a set of beliefs, norms, and values. It's also a system that structures the way that people view the world, and not everyone views the world the same. We have political differences, we have health related opinions that differ, and we need to be aware, maybe somebody's hemoglobin is dropping, but culturally they do not accept blood transfusions. We need to know that information. The last thing you want to do is send a resident for a blood transfusion that their religion dictates that they don't want. So that's a kind of an extreme example, but a reason that you need to be having these conversations. Cultural competency is defined as a developmental process in which individuals or institutions can achieve this increasing level of awareness, knowledge, and skill. Well, this is a continuum. This is not something that you're going to do a few presentations, go educate your staff, and then you're done. This will be ongoing and something that you should put at the forefront of your leadership team so that you can be aware of the residents that you're caring for in your area, as well as your community demographics. As demographics change, being able to pick up on some changes in your activities department or maybe your dietary department, you may need to look at some of those things. All right, so how do we reach this cultural competency that CMS has required us to carry out? Well, I mentioned earlier to value diversity, and diversity is different in every state, it's different in every town, it's different in every nursing facility. And so you need to know what your staff's backgrounds are, you need to know what your residents' backgrounds are, and really foster awareness and maybe special events around that. Most of us have Christmas parties, but we also need to know if we have Jewish residents, we need to be offering Hanukkah and some other celebrations that they may want to participate in. And some centers are very good about this, but if you haven't had a religious different resident in a long time, then you may need to revisit and look at your facility assessments and make updates related to that. We also need to avoid stereotypes. We're all guilty of this. I fly a lot, and I tend to be very judgmental at the airport, and people don't necessarily fly as frequently as I do. So I get very judgy. I can tell who flies frequently and who doesn't. So be aware of that. And education is key. Talking with your staff about stereotypes is okay. It's okay to talk about these things and identify where some of your gaps might be. Sometimes involving human resources can be beneficial, or if you have resources in your community. Susan, I'm not sure if your group offers anything along these lines for additional training, but I do want to know if you do have any resources in West Virginia for that you're aware of.
I'm blankly shaking my head. We offer a big variety of different training sessions. I can't tell you specifically at this time what our different ombudsmen have offered in the past, but we are looking at new things to offer all the time.
Okay. I was just curious. I've seen some things on the national level CMS has some trainings as well that are free, so I can certainly pull those links together and send those with the slides. And I think over the next several years, we'll start to see more and more resources related to this. It's important to do a self-assessment of your team and your building and the care that you're providing. What gaps can you identify from a training perspective, from a care planning perspective, from a dietary perspective, and really digging deep and making sure that you are identifying all the needs for all of your residents. Making sure that we're seeking out cultural knowledge. I mentioned, the education and training. Well, that's very important. But what are we seeking out? So without doing that self-assessment, you can't necessarily be intentional about those trainings. So I definitely encourage you to self-assess yourselves first. Incorporating into your organization, and if you have sister organizations, this value of diversity can be very helpful. And then also making sure that you're adapting to changes. I think every time I turn on the news, something is changing. And so we just need to be abreast and aware of what those changes are. And then also from a local community level, I mentioned the substance use disorder, and that's something that I think many states struggle with, but I think we can all agree that West Virginia has a very large population of individuals with substance use disorder or a history of. I would venture a guess that the majority of us have been affected in some way, either a relative or a friend. And so I'm not trying to be general in that comment, but we need to be aware so that we can provide services and care to these residents as they come in, and be proactive, because the residents that we have today are not going to be the residents we have 5 years from now. And so it's very important to start looking at your subcultures in your area.
Liz, before you move on, I just wanted to add one thing, and it's kind of a no-brainer, but as you're working through that checklist, please be sure and include the residents at every step. Otherwise, what you'll come up with is a nice book piece, but it will seem very paternalistic and artificial to the residents. So as you're doing your research and assessments, make sure not to leave out the most important source of information, and that's the residents themselves.
Absolutely. Thank you. Some other areas of diversity I wanted to cover: racial and ethnic diversity. We've already talked about local customs and preferences, religious preferences, obviously, and then gender identity and sexual orientation are all. And then how should this be identified? And Suzanne, you have great timing. So where should this be identified? Okay, well, talking with your residents, doing rounds, just having brief conversations. It's amazing what you can find out. Social service might sit down and do a brief assessment on admission, but then the questions are answered thoroughly, necessarily because that rapport hasn't been built. And so as the residents get situated in centers and become more accustomed with the staff, and they're building that safety and trust, they're more willing to open up and share some of these things. So it's very important that I would start from resident council and talk to them about some of the things that you are working on related to trauma-informed care, and get their feedback. What are some of the customs that they would like to see in the center? Are they happy with all, especially around the holidays, with the services that are being provided? And then talk with them about, as you admit new residents, you may want to add additional celebrations and decorations and those types of things, and just have an open conversation with them. They're a wealth of knowledge and usually are very supportive. So just keep all of that in mind. Okay, so the facility assessments need to be reviewed from a regulatory standpoint. You need to be able to capture your subcultures and in your facility assessments. And so I would suggest doing this in your demographics area. So you do need to include one, any cultural or religious practices that you're able to provide. Any language differences. So any residents that, obviously list English, but any residents that may speak additional languages, that needs to be captured in the facility assessment. And then also any values or preferences that you are accommodating for, take credit for those things in the facility assessment. So often facility assessments are saved, for that annual review, but they're really meant to be a working document. And to be updated as your population changes throughout the year. And so that's where I would capture those things. You also want to take credit for the resources that you provide as it relates to this. And so in addition to the demographics section, I would also include under your competency section, the training that you're providing to staff. And this could include your new hire orientation and onboarding, ongoing in-servicing throughout the year, and any annual education that you're providing. Additionally, I would capture the accommodations and resources that you're providing. So if you have additional services coming in, whether they be religious-based, support group-based, 12-step program based, whatever it might be, that you are taking credit for that in your facility assessment. Some elements of non-compliance related to cultural competencies are mainly failure to identify the cultural preferences. So again, to Suzanne's point, if we're not talking to our residents, we're not going to be able to capture some of these things. Not identifying a resident's past history of trauma. So I know many of you said that you're in progress with your trauma-informed care programs, and even if you're just starting, having some type of screening tool is the first step. And so again, I will share that at the end of the presentation if you did not already receive as an example. It does not necessarily mean you have to use the screening tool I share. There are many out there. I know Point Click Care has one that's built in that you can activate. Just be aware that you should not just stop at that history of trauma. Okay, yes, you have a history, but focus on those re-traumatization triggers and making sure that you are identifying those and carrying them out in your plans of care. You'll also see deficiencies related to not using approaches that are culturally competent. If you're caring for somebody with substance use disorder and you haven't even discussed, what their home life was like, what their background is, if that's not captured in the medical record, that's a red flag for a surveyor. We also are encouraging to update any pain assessments to incorporate a history of substance use disorder so that nurses are able to pick up on any type of diversion or any type of abuse situations or behaviors. Comprehensive care plans, this is a bare minimum, but you should focus on first describing what the resident's cultural preference is. What are their practices? Do they pray during a certain time of day? Do they need certain times of day where they're not disturbed? Is there certain music that they like? Certain foods that they can't have or that they want? All of that should be incorporated in. Also making sure that there are approaches and interventions that meet those cultural needs. And then lastly, making sure that you're focused on that risk of re-traumatization. It's important, we talked already, to collaborate for this process. And yes, residents should be number one on your list, as you see here, but also talking with family and friends, inviting them in to participate or even set up certain celebrations or activities. Now that the pandemic is slowly coming to an official end, it's nice to be able to offer some of those activities and visitation and other large group celebrations in the centers again. Also, making sure that you're talking with your healthcare professionals and providers that may have additional resources or knowledge for these particular individuals. If you don't know, ask. If you're caring for a resident that has a different religious background than you and you're not familiar with their customs, ask. It's okay to ask. It's okay to do research on these things, that we don't all know everything. And it's important that we're educating ourselves and just going with the flow and really going with the changes because our demographics are going to continue to change. The cultural competent care that we need to provide is going to continue to change, and we either change with it or we're stuck. So if you do have questions, make sure you're asking. Preferences can include, but are not limited to communication preferences, food, including preparation. I am going to tell on myself right now, and my coworker. I have a client in another state, and this client is a very large Jewish community. I have been going there for 5 years, and it never dawned on me. They put us in a boardroom when we worked there, and this year when I went, they came in to do a daily exit and they said, "Where did those cookies come from?" Well, my coworker had brought in cookies for the exit. Well, they weren't kosher. And she had brought those into their boardroom. And that was the only room in the entire building that you could not bring outside food or beverages to. You had to have the food that was prepared in the facility's kitchen. And that was a learning opportunity for me. I mean, I'm familiar, I've worked in kosher facilities before, but I did not realize that the importance. And so that was definitely a learning experience for me. It all worked out. No one was angry. It was just like, hey, now you know, and you can spread the word to others. So thanks for letting me share that. I'm sure you guys have other examples that you can think of in the back of your heads. Clothing can also be something that we need to be aware of. I know that depending on religious backgrounds, sometimes there's different garments that can be worn. Also during certain times of year, need to be aware of what they're expecting other staff to be wearing, what they're expecting themselves to be wearing for religious services during certain times of day, things of that nature. And again, you need to ask to gather that information. Having physical contact or being cared for by a person of the opposite sex, I mentioned this earlier, get a lot of questions about this. In certain religions, in certain cultural backgrounds, having a male caregiver or a female caregiver, if they're the opposite sex of you, is not appropriate. Having even a physician examine you is not appropriate if they're of the opposite sex. So we need to be aware of that and be able to provide the competent care that they require. Cultural etiquette also, eye contact, tone of voice. I've done a lot of work in Florida, and I was really inspired by the Haitian population there. The majority of my nurses and CNAs were Haitian or of Haitian descent, and I learned so much from them. So many times I had worked in centers where I was confused why residents would have complaints. Oh, so-and-so was rude when they came in my room. They won't even look at me. Well, in the Haitian community, if you make eye contact, it is a form of disrespect. And so making eye contact with a resident for them is showing a sign of disrespect. So I had to do a lot of training with my staff about what the requirements were for our residents, but also balance that with the diversity of the staff. And so again, having open, clear communication and asking for assistance and resources to navigate through that is imperative. Implicit bias, we all have this. It's just unconscious attitudes and perspectives that we all carry. Stereotypes are a prime example. They can be based on gender, they can be based on sexuality, race, and it's okay to have them, but what's not okay is for that to affect the care of your residents. And so when you are talking with staff and education is being provided, focusing on that point is very important. You need to make sure that you're increasing awareness and the need for that cultural sensitivity in the center, as well as provide education based on your demographics that you've identified. So if you take on a new resident that maybe they're a Buddhist and they need to practice meditation during certain times of the day, it's important that you do some type of training with your staff that are going to be caring for that individual. Being open-minded and not making any type of assumptions is very important. And then also talking with staff about their body language and how they may be perceived is important as well. And then continuing to build that relationship and rapport. Stress to your staff that if residents are sharing information with them, that they need to bring that to their leadership team, whether it be their supervisor or the IDT team directly, so that those interventions can be care planned, education can be provided if necessary, and things of that nature. Our CNAs and our housekeepers, the frontline staff, so many times residents build that trust level with them and share information, and it never makes it to the care team, the IDT team. And so make sure that you're including that in your educational practices. Some resource examples would be translation cards, communication boards. If you have interpreter services, I know some facilities are still using Google Translate, and there's nothing wrong with that, but you do want to make sure that you have more than relying on family members to relay information to residents. So do keep that in mind as it relates to language barriers and communication barriers. I would also recommend doing a specific in-servicing on that implicit bias that we just talked about, and cultural competence at some point when you're rolling out your programs. If you're still in the development phase and you haven't implemented some of these things, you can just start with that initial training of your current staff, and then just make sure that you're mapping that over to the onboarding process and annual education. So some activities that need to be considered. So we already talked about religious holidays, but be very mindful that you know every religious preference in your center. And this could be staff related too. Talk with your residents and your resident council, but maybe you have staff diversity more so than your residents. It's okay to incorporate celebrations related to your staff diversity as well. In the center, you can use it as a learning opportunity for the residents. Sometimes having different types of food prepared from other cultures can be helpful and also fun. So just make sure that you're discussing it with resident council and residents and getting their feedback prior to engaging all of that. Staff culture needs and preferences also may include certain time off to celebrate. So again, you need to look at your own policies and procedures, but definitely be aware that there could be some cultural differences from your previous staff. So just bear that in mind as well. Some barriers that we see. So making this a priority is the #1 barrier. We're all very busy with the day-to-day tasks, and making sure that we are putting this at the front and center of the care that we're providing, and making sure that our staff and team members are aware of the priority level, and so that everyone's on the same page. Making a survey approach can be beneficial. So Suzanne, you mentioned talking with the residents. I've seen surveys work, especially if they want to do something anonymously, but you can also survey your staff to see what types of differences they feel, or to get their feedback if they feel like you're culturally competent. It'd be nice to know what they're thinking in the back of their heads. Making sure that you're reaching out to local and state and national organizations. I will send some links for some resources, but they are also listed, as I mentioned, in the state operations manual. There's several links that are outlined under 740, F740, F699, trauma-informed care. Those are the main ones, and the focus is really, links to SAMHSA and some other mental health and diversity websites that are nationally renowned. You also should consider coordinating with resident families and friends. I mentioned, talking with them about coming in and or helping with organizing a celebration, or maybe there's a certain food that you'd like to provide for a certain activity. Having them involved can be very beneficial. And then making sure that you're talking with all of your team members. I mentioned the providers as an example. This could be your hospice providers, your therapy providers. Doesn't necessarily have to be your physicians or nurse practitioners and PAs. And draw on their knowledge and incorporate that into your processes. Financial barriers are also a big topic. So do we have the budget for this is a huge question. Well, being intentional about the activities that you're providing and the care you're being provided is always budget friendly. You don't want to be wasteful and throw money behind something that your staff and residents aren't supportive of, or if they don't feel it's inclusive, and those types of things. So make sure that you are drawing on those resources when you're working on budget development, and be very intentional about what your focuses are. Once you've done that self-assessment, surveys residents and staff, you can build out what is necessary. You want to make sure that you include all of your process changes, specifically if you do a self-assessment and you've identified gaps or opportunities to make some changes. Take credit for that and put that in your QAPI program. Make sure that it's reflected and discussed with a QA committee. You want to make sure that you're updating processes once those gaps have been identified. This could be policies and procedures. It could be your activities calendar. It could be the way that you're engaging with your staff. So really, until you do that self-assessment, you're not going to be sure what you need to address. And then lastly, make sure that maps over to the facility assessment. You do want to make sure, again, that demographic section is reflective of your current staff and residents. You want to make sure that the competency section maps directly from that demographic section. So for example, if you are taking care of, I'll use the Jewish population as an example again, you want to make sure that's outlined in demographics, and then anything associated with education related to those residents' religious preferences, food preferences, care preferences, whatever it might be, you need to map that over to the competency section. Does anyone have any questions?
Liz, I have a question. Everybody can put stuff in the chat and we'll ask the questions, but I have a question that somebody sent me.
Oh, yeah.
Do you have suggestions as how we can address residents who express problems with other residents who exhibit intolerance?
Yes. So the ombudsmen can be very helpful in these situations. I would suggest having a very straightforward conversation with the resident that is the concern, not being the resident that is not being very accepting and those types of things, and document that conversation. If the resident is harassing another resident, if they are outwardly vocal towards another resident or physical, certainly you need to follow the appropriate reporting processes. But sometimes reaching out to your ombudsman can be helpful. They advocate not just for the residents, but also for the culture within the centers. And so sometimes bringing them in to be involved in those conversations can be beneficial.
And Liz, I was going to suggest to make the education an activity or fun, included as part of a resident council meeting, or included as it, we used to many years ago do resident rights bingo.
Oh, great.
Could do something like that. Don't underestimate the power of a good cookie or ice cream. So make the education process fun rather than a confrontation with one or two particular residents.
Absolutely. And again, around, food preferences, bringing in those other diverse foods for activities can be helpful, and coming from an educational standpoint can be really fun. I've seen it work in ALs and assisted living. What other questions?
There's nothing popping up in the chat.
Okay. Wonderful.
Any questions anybody has, please put in the chat. If not, I'll do a little bit of housekeeping here at the end. Thank you, Liz, for being here. It was wonderful information. Take one or take two, either way. It was wonderful information. Today's webinar is available for CEUs for nursing, social work administrators, and activity directors. If you are an activity director on here live today, I will send you the link to the post-webinar test you need to take to receive your CEUs. Certificates will be sent out as soon as possible, and the recording will be available one day next week for anyone you know who missed it, or if you would like to review it again to pick up any other information you think you overlooked. The next webinar that we'll do for Trauma Informed Care Wednesday webinar series will be July the 19th at noon, with Suzanne doing transfer trauma and relocation stress. I will send the registration info out for that, hopefully later this week, but if not later this week, the first of next week. Again, if you have any questions, let us know. I can follow those on to Liz and we can follow up with them. If you were signed on and not signed on the way you registered, be sure to send me an email to let me know so I don't miss you when I do certificates. And also, when we sign out, the evaluation will pop up. If you could please take a few minutes to do that, we really appreciate it. We love to get feedback on what you think was good, what we can add, any other types of trainings we can give you. Again, thank you, Liz. Suzanne?
Thank you all.
Thank you, Liz, and thank you, everyone. Have a great afternoon.